Well, welcome everybody to It's Crazy. I feel like we just started this year and we're already finishing. This is the last installment of the START program before our annual meeting in DC next month. So we blinked and we're almost over here. But this is a fun open webinar session. Literally, we can talk and look at videos of anything and everything and take this in any direction that you all see fit. I know Evan has at least one video loaded up for us, and we can start with that. But I'll say it again. If any of you have a video that you want to just show us a quick clip or anything at all, we can review that and take it from there. So um, as far as housekeeping issues, I think Morgan already sent the faculty and all the participants information about when the START events will be at the annual meeting in DC. And so you have that. It'll be a fun little session, a little ceremony, and lots of festivities there. Other than that, housekeeping issues, Adrian, is there anything else I'm missing?
No, I think that's great.
All right. All right. Well, without further ado, no one wants to listen to me. Evan, why don't you take it away with the first video, and we'll
I
go.
just asked Dr. Stefanidis not to be too critical of my techniques.
Okay, yeah. So we recently did a VBG to bypass. I'll share my screen. This was a patient who had her vertical banded gastroplasty in 2003 in Lebanon. So she was only 59 years old. Let me move this out of the way. And she had a pretty severe stricture with dysphagia. I'll go back a little bit. With dysphagia, her BMI was only 19. She wasn't really able to eat or drink anything. So we offered her a conversion to a bypass. She had an upper GI and an EGD prior to surgery. Her VBG was done open in Lebanon as well. So this is kind of just for people who hadn't seen the VBG. I always have to review the anatomy of it because I never understand it. But this band can be made either out of like a silastic band or Marlex. So I think hers was Marlex, and then there was a non-cutting staple line going vertically. So this is kind of, I've got like 20 minutes of video. So if you guys want me to skip any parts or anything like this, but this is
Yeah.
kind of what we started looking at, like it was just like this plastered mess to the liver. We're kind of exposing caudate lobe right now. And if you guys want me to pause at any point, any questions or anything like that, but this is kind of this mess of adhesions that we're slowly getting off the liver. And then that was like the first point where we saw something that was a clue as to where we were, that little proline suture there. So at that point, we knew we were probably close to where the band was, and we kept chipping it off. And you can see some more of that material there. And that's when we thought, okay, we're probably getting a little close to it. I really don't think that I could have done this case without the robot, just in terms of the visualization. Sorry if the video is choppy.
Now it's a blue band. I've never seen blue Marlex. I don't know if.
Well, so that was like a blue, it's like a blue suture, and then you'll see the rest of the band. It's like a yellow color. So I don't know if it was Marlex or what, like I said, it was in Lebanon. Um,
But it
unfortunately,
wasn't a silastic band when you at the end of the procedure. I mean, silastic's pretty clear.
no,
Yeah,
I don't think so. You agree, Dr. Dan?
Yeah, this was mesh.
yeah,
Yeah.
And it could have been window screening for all we know in Lebanon.
So
yeah.
yeah, like you can kind of see it there. I'm sorry, this video is like super choppy. But you can kind of see that. So that was kind of our first clue, like where we were. And then our next goal was kind of to just get past that and get back to, the vertical staple line of the stomach and everything. And we were using pretty scissors pretty much for all of this, with a little bit of cautery here and there, and that made it really um this was probably the toughest part of the case. Would you agree, Dr. Dan, like getting this
Yeah, I
band off the
completely
liver?
agrees until you find your some kind of landmark for the anatomy, even if that means getting in the stomach. That's the hardest part of the case.
I'm gonna pause it for a second just to see if
Now, I
it'll.
know one trick that people use in these revision cases, which can be helpful in these, and I've done these before, is you give ICG and that lights up the liver so you can see where the liver edge is. Did you guys do that in this case by chance?
No, we didn't.
We actually did, and
Oh
it's
wait, no, we did it, but didn't we just do it when we were scoping, Dr.
yeah,
Dan?
we were doing it later. Yeah, but we do that for our revisions. It's a great trick of IC with ICG because the liver takes it up so uniformly, and you can tell the difference. But we didn't do it at the beginning. We just thought we were always close enough that we didn't need it, but probably
It was
could
a
have.
nice trick though to have, and especially in these revisions, they're tough cases. Any little trick can make or break your case
Yeah,
and save you a lot of time and effort.
yeah. So this is, I think we were at this point we were kind of like past that vertical staple line, and then it was just getting all this fundus off the liver. Um, yeah. Is my video really choppy for everybody? I'm sorry about that.
Yeah, it is, but I mean, I think we're still getting
Yeah.
snippets of what you guys are up against here.
Yeah, it was not fun. This took a long time to get off, and it was a lot of like trading back and forth. Like, all right, you go for a little bit, Evan. Okay, I'm gonna take over for a little bit, and but like it slowly came down. We did make a gastrotomy at one point somewhere like out here, but it wasn't anywhere near where we're gonna make our pouch or anything. So we're like, whatever. It
One nice thing, Evan, about these cases when you do a preoperative evaluation is to make sure that, with that stricture, the pouches tend to dilate significantly. That's actually a good thing because it gives you plenty of landing room to get a nice pouch done after. So if you see a very dilated pouch like she had, that's a plus. Hers was about 10 centimeters in length. The other thing, we weren't expecting a hiatal hernia.
Yeah. There's a picture of the hiatal hernia coming up too. But yeah, that was not a welcome surprise as we
But
came around to
did this
cutting.
patient have a preoperative EGD, or what was your preoperative kind of
Yep, I
workup?
did an EGD. I couldn't pass the stricture, but because the very in an upper GI contrast study, which showed a very dilated, somewhat incompetent esophagus from, she hadn't had anything solid in 10, 15 years. So I didn't foresee that she had a hiatal hernia like the one that you see there. Clearly, there's now this was a long, long case, and you could make the argument that maybe you just leave the hiatal hernia alone and get somebody better in terms of eating. And I didn't want to ever come back here. In addition to that, the dilated esophagus made it very hard to discern the hiatal hernia, and she was also from a social standpoint, she was the mom of a former medical student who's now a general surgery resident, and I just, wanted to make sure I get everything done that needed to be done.
Yeah, I don't have much of the video of the actual hiatal hernia repair. You can see that we've already got a Penrose here. It was a time-consuming hiatal hernia as well. But Dr. Dan, I feel like even if I feel like we needed the length, like
Absolutely.
I think we kind of had to, even if we really didn't want to. Um,
Yeah, I just want to take a second to make what's probably the most important teaching point of this whole case is there you could see we had done, I believe, the perigastric, could see the left gastric artery coming up, descending branch going down, ascending going up. But identifying this vascular anatomy is so important in cases where the anatomy is extremely aberrant because of previous surgery or unusual, you can have that splay over the right cruce, and you might say, "Oh, there's just maybe a short gastric coming up there," and it's really the left gastric. And taking that can really change your operation. So you've got to be really careful to get under that, lift that up, and then find your cruce, your left and right cruce underneath. Uh, Thankfully, knock on wood, I haven't been in a situation where I haven't recognized that and come across it, but I think you could probably get away with it. People have told me you get enough blood supply if you have a small pouch from above, not something you want to have to deal with. So just wanted to make that point, Evan.
yeah,
I think one thing, and Adrian, Demetrius, and I can't see the rest of whatever faculty are on as well. It can be tricky when you're making the pouch on these because you have your band, right? You're going to have to transect transversely proximal to where that band is, right? And depending on where that band is, you may have very little room, if any, between where that band is and where your left gastric is. Um, I've had a couple of revisions, not a VBG, where essentially if I had to transect proximal to the left gastric, so essentially excluding the left gastric, I mean, the pouch does survive. It's basically like you're almost like a cuff at that point.
Mhm.
But that can be really tricky to finding a landing zone for that transverse staple line between that left gastric, which is a little bit proximal, and where that band is on the VBG.
Yeah. And you can see here, I paused the video. This was our first staple line, and that little area there to the right, that's the band there, and we went transverse. And I think we ended up probably having what, like a four centimeter pouch or something like that.
I think it was easily 5 or 6 even, Evan.
Okay, so you guys had a nice
Yeah.
large pouch to work with, like Adrian
And
said.
you'll see it in a bit here. I think we
Yeah.
had a nice view of it.
We used a black load for this, and it did bleed quite a bit. Like I remember we were buzzing that staple line, but it felt so thick. I don't remember this in the video. The stapler doesn't really stop, so I think we maybe even could have gotten away with the green to start with, and we went with greens for the rest of it. But I think we were just like, oh, this thing looks really really thick and dilated. We should try to do a black load to start with.
I think Demetrius, are your hands up, or you can just jump in if that's what you're trying to do over there.
Yeah, so couple of comments. With this case is one of the reasons it is thick is because oftentimes the stomach is folded upon itself. And in addition to this, not infrequently it's twisted. So one of the first ones I did, at that point I was doing laparoscopically and I was using a transoral anvil. After I created the pouch, I opened the hole inferiorly, trying to bring the NG through, right? And I could not, even though the NG I could see was there and I could see mucosa, I wouldn't see NG. And I'm like, what the heck is happening? And then I realized at some point that I had created essentially a blind pouch. Doesn't make sense because of the twisting, even though from the outside it looked like I had a regular pouch, fine. There was a little bit twisting, and there was essentially the excluded stomach that had stayed a small piece on the pouch, and then I had to create a second hole essentially to get into the pouch, if I'm making sense. So this can happen. So what I do want to do in this case, I try to really identify where the staple line is now, because oftentimes what happens if the staple line is here, the stomach folds like this on top of it. And then if you don't dissect it out, it will never be too thin, and you may end easily go into one or the other side without realizing it. And it also increases your risk for staple misfiring because if it's too thick, obviously the staples won't go through. So I
Mhm.
tend to oversaw this every time too, especially with a robot, it's easier just to ensure that that doesn't happen. But that's a couple of things I've encountered doing this.
The one thing I was going to add to that too is how early did you guys get your endoscopy involved? Because that's one thing that can be really valuable
Yeah,
is get the scope down there and
yeah,
just see what's going on the inside. And if you can
yeah,
do Tile Pro right on the robot, it's really nice. You have both views at once.
yeah, we had our EGD in before our first staple fire.
And,
So we like brought the stapler into where we thought we were going to go, and we had our scope in verifying that everything looked straight and that we had enough length on our pouch.
and once we've created the pouch for this exact point that Dimitri is making, we scoped again to ensure the integrity of the pouch. And that's right about there, I think, somewhere we did.
Yeah,
We're hoping
yeah,
to do a linear stapler, but it lends itself better to a hand sewn.
I think, just switch operations as we're watching this, but like when you're doing like a band to whatever sleeve
yeah.
bypass, the plication sutures. Before I start firing any stapler, I get that scope down there because, like Demetrius said, if the stomach's folded on itself, A, it's thick, but also if you start stapling across two layers, you're going to get obviously an inevitable staple line failure and leak. So it's another useful trick to see, insulate the stomach. You can either clamp the just over the pylorus, you can clamp the ligament of Treitz or whatever, blow that stomach up and see that there's no folding or any plications, or in this case, adhesions around the vertical staple line. before you start firing anything, because you can't undo a stable fire, obviously.
Yeah.
Absolutely critical to use endoscopy. I fully agree.
Yeah, we used endoscopy a few times during this case. And then so after we made our pouch, like we decided that we were going to resect a good portion of the stomach that had this old mesh in it and had the vertical staple line in it. So that's kind of this portion of the video. I'm curious how many, I guess we have two faculty members, but do you guys usually resect that whole area, or have you? Pros and cons to doing that?
I usually do resect it. Lately, a couple of cases I've done, I didn't fully because I was fairly certain I was right on the previous staple line where I divided it. But oftentimes it's really hard to tell. And for the reason I mentioned earlier, trying to avoid creating blind pouches, whether it's on one side or the other,
Mm-hmm.
I try to remove that stapled area and the band, especially if the band has erosions and stuff.
Hey guys, it's Liz Hooper. I almost always remove that fundus with any leftover Marlex or silastic band or whatever stuck right there, and then that fundus from that vertical side for that exact reason. Agree with you all, endoscopy definitely key here. And then obviously, you know, 13 years into practice, this is a case where I want to know where my partners are. I'm not doing this alone. So please don't feel like you guys need to be ready to do this case alone, fresh out. This is a have your buddy with you kind of a day.
I think when my partners found out I'm doing this case, they all left town. I knew where they were.
Yeah.
Yes, but you had Evan, so.
Exactly. Well, that's a great point. So
I think one of the things too that can help with exposure in a lot of these revisions is whether, obviously, if you take the short gastrics, then you're really committing yourself to excluding and obviously resecting that fundus.
Yeah.
And if there's a hiatal hernia, it can really be helpful to take those short gastrics. That allows you to roll up the stomach and give you posterior exposure. That can help with their dissection. Obviously, if you do that, it's not a big deal, but you're committing to do that fundectomy. And so I think more often than not in these cases, I end up doing that. I like doing it. I like the exposure, and I probably going to take it anyways. I don't always trust whether I'm going right over top the staple line. It's really hard, surprisingly hard to figure out where that old staple line is. It can really be hidden or buried or all the above. So I don't know if anyone else has.
Yeah, and sometimes
Stabilize that.
sometimes they're fistula right in that staple line. So there's not really a staple line in some of the areas. One additional advice and comment is sometimes they're really stuck posteriorly. So you can really create that window to put your stapler on the back side. So in that situation, I think what works best is if you come across completely and then use that to lift everything up to go underneath it, because
Yeah.
if you try to do it with a stomach remnant still stuck, you will never get, meaning it's a lot harder. So that can be useful in that situation.
Yeah, I wish the video was better quality. I apologize for that, but that's exactly what we ended up doing, Dr. Stephanides. We were just like, all right, let's just staple across it and then lift everything up, and then we just took everything with the vessel seal from the bottom side. So
With
then
GJ revisions, like say you got a perforated ulcer, the same thing, cut across the roux limb, you're committing yourself at that point, obviously, and then you can lift everything up to get a nice posterior view. So.
Guys, hi, it's Faiz. Sorry for joining a little late. But another trick that I do is go in endoscopically and then put a suture where the vertical staple line is. So you need to exclude that part, and you can actually retract it laterally and then come through your with the stapler. So you're actually pulling out the stuff, the part that you want out using a suture. So I've done that a couple of times when you're not entirely sure and you don't have enough tissue to kind of pull it laterally. Using some sutures can actually really help in those circumstances. And I have made quite a few micro pouches too, especially when I was converting a SADI to a bypass with the previous sleeve leak. I thought I could just come below the sleeve where the leak was and then leave it at that, but there was just too much fun of stomach and there was a hiatal hernia, so I had to go through that part. And in those circumstances, I just put a stitch in, grab the stitch, pull it laterally, take your stapler and fire it.
The rest of the video is just our bypass reconstruction. So we did a 2-layer hand sewn. We were playing with the thought of doing that new 8mm stapler, I think, but it just lined up really nicely for a hand sewn anastomosis. So this is our back layer. Oh, now the video's nice.
No, it's not.
Yeah.
And then were you guys able to endoscopically see the fistula vertical staple line, or how did you guys decide where to do your vertical pouch?
We could kind of see the indentation of it, and we just went medial to that. It wasn't super visible, but it was fairly obvious.
And did you guys put a bougie down or anything to make sure you didn't make your pouch too tight or anything like that? Anything sizing?
We had the scope in the whole time, pretty much. Yeah, we were kind of using the scope as our bougie. Back to bed video. So here's our gastrotomy. I want to pause the video here because I skipped the part in this where I made the enterotomy, and I was hoping for pointers on getting it to not bleed when you make the enterotomy for these hand sewn GJs. Because I feel like every time the gastrotomy, it doesn't seem to bleed that badly for me, but the enterotomy, I always like go in on cut and then snip as I go in, and it's just like a bloodbath that I have to like tap with a cautery a bunch of times. Does anybody have any pointers for that?
So Evan, I'll take that. One, you can do it in 2 different ways, and I've tried that. One is to set your cut on very high temperature, like on the DV5, I go up to 80, right? Now, or go on coag on a lower one. So
Okay.
both works really well. And if I'm doing my JJ, I actually use vessel sealer, 2 beeps, and then cut. So it really bleeds.
Okay.
Anyone else?
I agree. I would use the cog to do this, and then it won't bleed as much, or I use synchroseal for that same reason.
There it is.
Mhm.
Yes, interesting. I actually have a
It
question.
would work well for that.
If we have time, I might want to share a video and ask Dr. Stephanie Reeves for his opinion, because there was one case where I was doing the same thing where the fistula was, or where the leak was, it was all calcified. I couldn't get my scissors. I couldn't get my vessel sealer. You think the synchroseal would have helped there? Because I think a harmonic would have helped in that circumstances, cutting through that tough tissue. But does synchroseal kind of work in those circumstances?
Well, it's a bipolar device, right? So if for whatever reason, so the issue maybe that may have been happening is if you have clips or previous staples, it won't activate. It's the same like with a regular bipolar you're using.
It wasn't the clips.
Yes,
It's
I'm
yes,
sorry.
the tough tissue. Like, sometimes you get that calcified tissue where there's a lot of inflammation. It was one of those things.
It's a little sharper than the vessel sealer, so potentially, I don't know, it depends, I mean, on the case.
Right.
Evan, I think using coag is maybe the way to go, but you're going to get a little bit more thermal spread, so you have to be very mindful. Whenever I'm doing a hand sewn, I like to kind of tap my start and my end, and then I'll kind of take the serosal layer, and then I'll go right in the middle. You could do it on the G side of this. I'll do it with air through a Visi G. When I'm doing a DS, I'll have a little bit of air poofed in, and so as I go into that opening, I get a little bit of air between me and the back wall, and then I just have to be really careful on that small bowel side, lifting it up as quickly as you can. I prefer to take both tines of my scissors, close it, and kind of poke in with that on coag in the middle of what I've already scored, and then go in one tine in and lift up and coag as I cut down the length.
Yeah.
Yeah,
I don't
Go
think
ahead.
it makes a difference if you use coag, honestly. I really, even if you have it in the higher setting, as long as when you saw it back, you make sure you stay away from the white area. You incorporate that in your suture, if that makes sense, where it's coagulated essentially.
It actually forms you a nice little line where you know you need to be beyond that. So I do like the coag part of it.
Yeah, I use coag, Evan, and then I do like for the bowel, not so much of the stomach, but the bowel, you do like a quick snip with coag just to kind of
Mhm.
get through the serosa, or you can do what Dr. Hooper said.
Yeah, I've
And
been doing
then
like a
then
quick
pop
snip
in with
on
coag that
cut.
way.
So I guess I'll try coag now and see if I like that better.
But I think one of the things, I think the robot, the visualization is so good and the magnification is so high that what may look like a bloodbath is just a drop of blood. And, just putting a little bit of pressure with the right deck on it works for me. I mean, you look at it a minute later and it's gone. Maybe a little bit of coag to finish it up, but I don't know that I've had that many problems with that.
Yeah, I agree, Dr. Dan. I think I'm just really anal about it. I hate having any bleeding when I'm trying to, do this and it. So yeah. I know you've told me to calm down on that multiple times, and I can never let it go.
Well, as a surgeon, you have to get used to bleeding. So
Yeah,
I
yeah.
think one of the important things, though, that Evan and all of us is like Adrian said, this robot, it's 10x is very magnified, it's very clear imaging. And oftentimes, if you start coagging and doing stuff after the bleed to try to stop it, you're going to cause more harm than good. So if you are concerned, not that's a good time to just take a deep breath, grab it, pressure, whatever, before you start, trying to coag and just blindly go after things, because then you can cause some, real damage and get yourself in more of a hole.
Yeah, while we're talking about that, just something to bring up. When you take robotic bites, especially on the inner layer, you may think it's a big bite. The robot really magnifies things. You need to take a big bite so you can have enough tissue that's a reliable closure. So always remember that bites are smaller than you think.
Evan, going back to the VBG, I just a question for you. The band, the part of the stomach with the band, so just distal to where you did your transverse section. Did you just exclude it and leave it alone, or did you resect that part of the stomach? What did you guys do with that?
Yeah, we resected that. Yeah. We ended up taking a good amount of stomach out actually. Just because after I took down the shorties and then it kind of demarcated, like there was like an area of the stomach that just looked like it looked kind of ischemic. So we ended up taking out all that fundus and a good portion of the stomach.
We stayed above the antrum though,
Yeah,
so
yeah, the antrum's still in there. Yeah.
I thought you liked the blue intestines.
Luodinum.
Actually, yeah, like I've got a Sadie video, although my video quality is terrible. I don't want to keep torturing you guys. This is we did our JJ with the 8 mm stapler. I don't know if anybody's using that for their JJs, but this is a horribly
I
buffering
use it for
video.
my appies. The beautiful cases you can be done within 6 minutes with an appy.
Oh yeah, that's a good use for it. I haven't thought of
Yeah.
that.
I'm gonna do it. I want to do it, and I'm gonna do a bypass, a full bypass with 8 mm stapler. Have any of the faculty on the call done that yet?
I've seen a video of Curtis Perry. It is going to be painful, man. It is like the 3 mm, the 30 mm is way too small. Good luck.
I know it's a
I've
lot of
done
stable
I've done
fires.
the GJ and I've done two JJs, including this one, and been very happy with it on the GJ and on the JJ. But I don't know if I'd want to make my whole pouch with it. I'll just open two staplers. I know some places don't let you do that, but
I was gonna say, did you feel like your pouch was super long because you had to keep getting reloads on the vertical?
no, I did. I just did the GJ, not the pouch. I did the pouch with
Okay.
the regular stapler.
Yeah.
I feel like my pouch would be smaller because I wouldn't want to take so many fires. So I'm gonna be like, you know what, this is gonna be really small because I don't have the patience for this.
Yeah.
All
This is
right, Evan, what else? What
That's
else in
pretty
this
much it.
case did you want to
I,
discuss?
I would actually say one of the scariest parts of this case, and this video was like super long, so I cut it short. But one of the scariest parts of this case was closing the mesenteric defects because you can see there's like, what are you going to close? Like there's like no fat.
There's
Um,
nothing.
And fortunately, we didn't get into any bleeding. We just took like these little delicate bites, like lifting away from the blood vessels. But that was it was a little hair raising. But we were like, well, we have
And
to.
you do, however, have an advantage in this situation. You can see where the vessels are,
That's
so
true.
you
Yeah.
know how to avoid them. Because when there's a lot of fat, you don't see where they are, so you kind of go blindly to some degree. Whereas now, yes, you don't have enough tissue, but you know where not to be.
Hey, Demetrius, so this lady had her VBG in 2002 in Lebanon. Were they still doing them in Europe at that time?
Around the time, I think they were still doing them here because I still see a bunch
You
in
still,
Indiana from that time, VBGs.
yeah, I know there are very few groups, and by 2005 they were doing them anymore.
Yeah. If you look at the ASMBS data, there's still some VBGs recorded today. So I don't know who does them, but there's some still happening. Few.
Amazing. Wow.
That's crazy.
That is-
Going back to the mesenteric occlusion, Evan, though, like when you get some of your long-time post bypass or switch patients that have had significant weight loss and they have an internal hernia, right? Their mesentery looks like this right after the weight loss. So it looks very different than when you closed it before, when the leaves on the tree, right? And the tree's nice and full. It looks very different than when they lose the weight and it looks just like this. Which also maybe lends to the idea of why the hernia happened in the first place too. So okay.
Yeah.
Anything else on this? Anything else, Evan, that
No, I mean that's the VBG video. I have another video of a Sadie dissection, or if any of the faculty have any videos they want to share, or if any of the other fellows have anything.
yeah, I was gonna open up to the other fellows first. No one wants to watch us and hear us talk about ourselves or what we do as much as we want to see what you guys are doing out there. Anyone else have a video of any kind or a snippet that they want to throw on the screen that we can talk about? It doesn't have to be anything edited, like I said. Does anyone have anything?
While someone's grabbing that, let's discuss Shimke's drawing of himself on his back counter there. That's nice.
Yeah, I trust me, I did not draw it. If I drew it, it'd be a stick figure, so I can't take any credit for that. But you also notice, like, I have two kids and only one kid's even in a picture. I need to update my pictures. They're a little outdated. Yeah.
Yeah. Demetrius, you said something about VBGs. I had to do a peer-to-peer today about a patient with Aetna insurance, and the peer thought that I was asking to do a VBG, a vertical banded gastroplasty. And I was like, no, the code is for longitudinal sleeve gastrectomy. And he's like, well, it says vertical. And I was like, that's not the identifying feature of the procedure.
ESG.
That is funny.
At least he was like, oh, well, I reread it and I talked to a colleague and it's okay. We're going to overturn it. I was like,
God,
yeah,
if we don't have another one, should we just go ahead and look at the section for?
Yeah, I have a.
So
I'm
we
going to bring
don't
up a
divert
discussion
to
topic. I don't
digress.
have a video, but
Okay.
Abby is on the call, my fellow, and we're in the midst of this right now. So this is something that you guys will encounter all the time if you do gastric bypasses, which is kind of the pros and cons of doing the JJ, either a single fire, right? Single fire of a 60, and then oversewing the common enterotomy. And there's a lot of different ways to oversew it, but versus a bidirectional or a triple fire or whatever you want to call it. I traditionally, I do it both ways. I was on a streak where I do bidirectional. And of course, then you see those patients in revisions or you're in the abdomen for other reasons and you see that big, football looking anastomosis, which doesn't make any of us, I think, feel warm and tingly, but, it works. But then, of course, intussusception and issues with the
twists.
bidirectional. What's that, Adrian?
It twists the mesentery too.
Yep. And then there is the single fire. And The single fire is lovely. It's beautiful. The sewing, the enterotomy, it's great. It just looks good. But there's obviously the high risk of obstruction, stenosis, things like that. I want to know anyone here faculty's experience with that, because we've done it both ways, and we have a patient currently in the hospital right now with the single fire who shows a CT. Contrast gets through that, JJ. There's no internal hernia, but it's a little tight. She's about 5 days out. So I'm curious. I want to hear faculty's experience with both and what they think.
If you go back and if you have video, did your fire actually fire the entire length, or do you think you have a short length of anastomosis?
It's an excellent point. I mean, we had to reposition it a few times, but in the end, we got the full length on there. And the way we closed it, and the way we closed the common enterotomy is 2 layers with the same stitch. So just a running up and then the same stitch of Lembert back down.
So Scott, I'll I had this discussion with Evan just a few days ago when we used that 30 millimeter. Evan was very nervous about the 30 millimeter being too small. The
He's
30
okay.
millimeter,
We were arguing about it, like full on arguing in the operating room.
the 30 millimeters is what allows bile to drain from the BPL to the common channel. That could be a centimeter. It doesn't have. The issue is how not to tighten the roux limb to the common channel, which is where food and contrast would go. So in my opinion, it's just my opinion, as long as you're careful about where you make your enterotomies, so you're kind of on the mesenteric side, on the inside of the anastomosis, and using a 30 millimeter actually decreases, it makes the opening smaller and decreases the amount of sutures that you have to place, and because the enterotomies are smaller, it actually decreases the likelihood that you're going to have an obstruction there, except for a pseudo obstruction where you have to align the bowel with what's traditionally known as a Brolin stitch. But yeah, when we have those big enterotomies there from the larger staplers, that 60 millimeter does not give you any additional passage of food. It allows more bile to drain down, which it doesn't need, but you do have to take more sutures, which could potentially tighten the passage from the roux limb to the common channel. So that's my take on that.
So Scott, when I was, I don't know, initially my career 2-3 years out, I did see a few obstructions at the JJ. I used to do a one single firing. And then I decided I'm going to do double stapling. That was laparoscopic at that point. And then I wasn't really seeing them. When I started doing things robotically, I transitioned back to the single one. You have a little better control, I guess. So I haven't had many issues, but recently I have seen a couple. I have now somebody in. I did a 93 BMI last week, and she came back with with a narrowing at the JJ. But my impression is that is not just the how you construct it. If they bleed, that the clot will stick to that anastomosis and will obstruct it. And she started having some bloody black bowel movement, so that probably was a component for her. She's doing already better. I didn't have to operate on her again. What I try to do is I try to do also the Brolin type stitch to kind of stem the anastomosis so it doesn't kink right where you create it, right? So even if you do one firing, I'd attach it farther down so it doesn't, because the bowel has the tendency to kink right where you create the anastomosis. So, and I try to stent it there, try to reattach it farther away so it cannot do that. That's what I do now. Most of the time it works, sometimes it doesn't.
Do any of the faculty, most people do an omega loop, not everybody, but do any of the faculty divide the mesentery a little bit? And I know that's one of the things that we always talk about is to try to take that sharp turn out. You can use a Brolin stitch, or some people can to divide the mesentery. Do any of the faculty divide the mesentery after
I
they
think
do
you
the
have to
omega?
do both, Scott. And I take 2 fires with the vessel sealer, and then I think the key is where you make your enterotomy. You have to be a little bit away from the staple line, so you have a centimeter or two to align backwards, right? If you don't do that, you have nothing to align it to put your bone stitch. So, and you can't be completing the anti-mesenteric because then you're gonna take more suture. You have to be a little bit on the inside of the anastomosis.
Seconding Adrian's point, I do use the vessel sealer to divide the mesentery a little bit, but I never used to do that before, and I didn't have problems with JJs. The couple things that I do is like Adrian said, staying away from the staple line just helps you kind of get that anastomosis a little lower down. And then when I make my enterotomies on the BP limb, it's a 3 o'clock position. And on the rule limb common channel, it's at 9 o'clock position. So it's sitting one on top of the other. And when you're closing that, and when I'm closing my mesenteric defect, I kind of make it like a nice little slope. So it go all the way up to my previous staple suture. And with that, I feel like because it doesn't kink off, I really haven't had problem. The one time I had problem was when the JJ bled, and just observing that, I mean, there's going to be a big clot. So I just sat tight on that, and it kind of resolved on its own. But other than that, no, just making those enterotomies. And I think that's what we did in our fellowship to 3 and 9 o'clock kind of position, not completely anti-mesenteric.
Scott, can I ask you with your current patient that's in the hospital, have you given a thought of putting a camera in? Every time I've done that in this situation, I've walked away thinking I'm glad I did. Even particularly when it wasn't my patient that I knew what happened on the initial
Uh,
by
yeah, she just came back yesterday. I discussed with her today. I haven't decided whether I'm going to pull the trigger or not. I haven't decided, but I mean, I've never regretted going back. But you're always a little gun shy. You're like, oh, it's gonna get better, and you convince yourself it's gonna get better. So, I may have to. We'll see. I haven't made that decision yet. But
So I recently had that case with one of my partner's patients. It was on a Sunday, of course, um, and I said, you know what, I'm going to take this. It was done laparoscopically. I said, I'm going to take it back robotically. It drove everybody nuts because we're still at the point where they're like, you're going to do what? And I said, yeah, it's going to be fine. So what we found is that the raw surface area and the barbed suture on the JJ was stuck to the opposite side of the limb, kinking, pulling everything up at a very acute angle. So we just opened that up, and it was nice for the resident to be able to oversew that area with a new suture robotically. And they were very happy that we did it robotically at that point because they got to do the case. So
yeah, in this case was robotics. So I mean, going back in, you use the same incision, so I mean, it really wouldn't be a problem at all. And we very well might be back in that abdomen. So stay tuned.
Scott, I have a spectacular complication video. Not that I'm proud of it, but if you guys want to watch it, I can play it.
Sure.
And I don't see our fellows, so that might be good to avoid the PTSD.
Yeah, you have a video or?
Yeah.
Oh boy. All right.
All right. So let me get. All right. So this is a GJ revision patient we did a couple of weeks ago. And can you see it?
Yeah, we can see it.
So here we have the tile pro, right? So we're looking at inside, looking at the anastomosis. We already, have, as you can see, have done a lot of lyse of adhesions anteriorly separating the liver up, and trying to exactly determine where the anastomosis is essentially. It's still stuck laterally. So I'm trying to figure out if I have enough space to because this is I failed to mention this is a second revision. It's the first we're doing, but she already had a GJ anastomotic revision for ulcer. And I'm trying to assess if I have enough pouch to create essentially.
Are you revising it again for another ulcer, Demetrius? Sorry, I missed.
Correct. Chronic
Okay.
ulcer pain, etc. So that's why we were doing the endoscopy here. but it's coming here in a moment. So we're trying to go through. It's scarred. This is the lateral aspect. We have already separated some. The remnant over there. One second, now it's gonna get interesting here. Nikki is doing this at this point. Let me see if I should forward this a little.
I'm like almost nervous right now. I don't know about anybody else.
I can't wait.
So now we're trying to go behind it, right? So to see if we can separate it. You see how the tissues are, is like they're swollen a little. It's chronically inflamed here. All right, so we're finding this plane.
I have to go to another meeting and I don't want to leave.
Don't leave, stay.
And I'm staying.
I'm trying to remember where the issue is, but I think we get that.
I think we have 30 more minutes, so we'll be good.
We keep going from side to side. I don't know if this is going to be a left gastric or a splenic artery you're about to show us.
All right, so here we're going laterally.
Okay.
Don't do it, Demetrius.
Okay, let's do it. I say splenic.
We're separating the remnant, right?
You know what? I say cava.
Oh no.
Oh, wow.
Don't say
wow.
the C word.
I want to go big.
Don't do it. Oof.
No.
These are all nice planes right here, though. Like this feels like you're
Safe.
making progress, and
Yeah, this is almost satisfying watching this part right now. It's like, come
yeah.
on. Yeah. Oh, the splenic's gonna win.
Splenic. Splenic.
That
Ooh.
guy right there that we're holding.
What are we holding there?
What's that?
This is just a scar tissue essentially
Okay.
to the pouch laterally.
Okay. Looks
So far we're winning.
This is a horror movie, right?
we're all
This
like,
is-
I can't take my eyes off this.
Yeah.
It's gonna happen now. Anytime, guys, now.
I'm just looking at everyone on the screen. Everyone is like glued right now. You have everyone's attention.
Everyone loves the trade rack.
Right.
Just
This is
happy
like this is like people looking at the accident on the road.
Right.
There it is.
Oh,
Shit. What is it?
So I wanted to show you because it's really hard to tell, but if I go back, you will
Yeah,
see
what
the
happened
splenic.
there?
You will see
so
the
subtle.
splenic. 1 second. Let's
Okay.
see. Watch it one more time because I'll show you how much is bleeding in a moment. I haven't shown that yet.
Okay.
Okay,
But
so a little buzz.
Okay. That seems like a clean plane there, right?
yeah, it's a little farther down actually. 1 second. Let's see.
Yeah, there. Oh,
Where?
I'm sorry. I'm going a little faster so I can get back to the point of interest.
Okay.
right. Is it that cross beam, whatever that thing is right there?
It's already started to go here.
Okay. So
Not yet there yet. Sorry, one moment. We're getting there.
It's okay. You can just let it run. It's right
So the
behind
question
that.
is, okay, so we got, you'll see in a moment, but we got into the splenic vein, and actually it's a pretty nice bite, shark bite on it, about 50% anteriorly. You'll see it later. So
right
what do you
there.
do? What do you do for the fellows? We didn't want to
grab
be
it if I can to stop
this
the
is it. This is it. Watch
oh,
this.
there it is.
See the vein
Oh.
here?
Mm-hmm.
Fudge.
It looks like the same. We didn't recognize it.
Yeah.
Boom.
Yeah. Oh, okay.
Do you see it?
Yeah.
It's it's like pancakes flattened. It looked just like almost.
Correct. It was
Yeah.
pulled up essentially with the adhesions. And I think the issue here was that we were a little farther away from the pouch. We shouldn't have to be that far away. So we got into it. So what do you do now? There's a lot of bleeding. Here we're trying to, and we cannot see where it's coming from because every time we try to expose, it
That
just
looks
fills.
that looks like robot magnification to me. It's not that much blood.
Adrian's never had bleeding ever. Never.
I'm kidding. That was a joke.
So what do you do? What would you do?
I would grab each side with an instrument and just try to figure out how I can throw some stitches in.
Well, first of all, any revision case, that's why I love having a ray tech in, because like if something like this happens, you just take that ray tech and you just smash it down there, catch your breath, figure out what's going on, call for help if you need it. Make sure you got the instruments you need. If you need the problem with the robotics, right? If you don't have that ray tech in there, you want someone to put it in there, in a second, that's just not going to happen. So it's really
No.
nice to have that ray tech available if you need it.
Oh yeah, rating is always part of the game with revisions, no question.
I think at this point, I would open a suction irrigation robotic one that allows me to put a pressure and then kind of, if you just slowly roll off, then you can see and grab with one hand and then see if you need another. Like if that was the point of bleeding, but you need to go on both sides. So
What
Adrian,
do
you're saying you're going to ligate, you're just going to ligate the whole thing?
Now here we are
Oh,
lifting up the remnant so we can see because it's in our face.
Right. Yeah.
And I know
So
I'm going to spend
Okay,
some
that's a very
time
good
there.
point. Yeah.
I know I'm going to spend some time trying to fix this, so I wanted to have it out of the way.
So you have it controlled with like a ray tech and just pushing down on the bleed right now while you're
Correct.
doing this?
Correct. Yeah, the third arm is pushing that rating down to control
Yeah,
it,
okay.
if that makes
yeah.
sense.
I think it's a really good point. Like, you only have three basically working instruments. So if you can retract something with a static retractor, that helps. And then if you need to get get an assist port so someone can have the sucker coming in from like the patient right, kind of lateral to arm one, and that way you can keep your suction in there.
So we already tried a couple of times to go directly to repair it, as you suggested, Adrian, but there was so much blood, I couldn't even see where it was coming from, so it wasn't working. So here we decide to isolate the splenic artery to take control of it.
Mm-hmm.
Problem is, I know bulldogs probably for the robot exist. We don't have any. So I'm opening some laparoscopic ones trying to put there, which was interesting. We were completely unprepared for this. Anyway, so
I
we
need
get
a
go ahead.
question maybe for like the urologist, because how do they do these when they're doing like a robotic nephrectomy?
Right. It was also late in the day, so there was not really many people around. So I'm trying to use that laparoscopic bulldog clamp with a robotic grasper. Eventually, I'm able to get it around, but it's not really working that easy.
Probably need like a pro grasp to get more grip strength to activate that.
Yes, you're correct. We ended up using a progress to do it. Here, I'm assisting with the other hand.
But why not just put the bands that come, what's that called?
Like a
Endo loop,
vessel
endo
sealer
loop.
or a vessel loop?
Yeah, vessel
Yeah,
loops.
vessel loop, yes.
Yeah, I
We,
was gonna
we
say
did,
you could just
we
use a
did
vessel.
use vessel loops later for the vein. It didn't work that well.
Or
Let's see.
didn't.
So here is the hole. You'll see it a little better now that we've isolated things a lot. And the bleeding is not necessarily much less.
Did,
Okay, guys, I gotta go to the other meeting. Oh God, I want to watch this before I leave.
But you can see the hole. It's a pretty fair size hole right here. Essentially, I end up doing, mobilizing the vein before, after, is still, I put the vessel loops around. It wasn't that great. It didn't work that great. But eventually, I was able to get enough, I guess, inflow control or outflow control here. So the hole is right under this suction here now. But now we can see at least where it's coming from, if that makes sense.
Yeah.
Do you repair this or do you actually ligate it? You just
I repaired it.
okay. All right, guys. Thanks.
Follow.
So we ended up repairing it. We can show maybe the repair. Here I was able to grab it finally with, these are the endoloops. You can see the vein, but here's the hole. See the hole, how big the hole is?
Mm.
Yeah.
So all this is a hole where I'm putting my hand in. And the only way I could make it stop is by grabbing essentially proximally on the vein or distally, proximal to the spleen, to be able um, to repair it. Needless to say, I lost a few years of my life in this case.
Yeah, I don't know. I would have just ligated that.
Yeah, I was gonna say, like devil's advocate, why not just ligate it?
We could have, we could have also removed the spleen, but I guess I thought I should probably first give it a try at fixing it. Then I started using this 5-0, 6-0 or something. I would break it every single time.
Yeah, you really have to watch your adrenaline in these moments with these
Yeah.
little sutures and veins.
Eventually, I went over the learning curve with a 5-0. I was able to not break it, and then we were able to fix it. But it was very painful.
So,
You only lose 5 years of life if you ligate it, 10 years if you try to repair it.
so do you anticoagulate this person afterwards for fear of a
So
portal vein thrombus?
so we anticoagulated her um, uh, after surgery. We did an immediate duplex that was showed it was patent. And then she came back 10 days later with a bleed somewhere else. You can never win. So we had to stop the anticoagulation. But she also had some swelling at the new GJ anastomosis. So that improved over this past weekend. And we rechecked with a duplex and it was fine. And at this
I think this
point,
is an amazing
there's the repair. There's the repair.
Yeah.
to
Doesn't look
show. I mean,
perfect, but it did do the job.
I think even the most skilled laparoscopic surgeons in the world would it would be tough, really tough to do what you just did robotically.
Yeah.
You know, getting that exposure, getting the suction in there, sewing with 6-0, whatever.
Yeah.
I mean, you know, this easily could have just ended in an open splenectomy.
Yeah.
And
With
so,
MTP.
yeah,
Correct.
yeah. I mean, that is a very, I mean, very cool example of just the abilities that you can do with a robotic surgeon. I mean, all the benefits of the patient. I mean, guys were able to pull it off.
I mean, if it was laparoscopic, I probably would not have done it. Truth be told, I've gotten into an iliac vein during a lap inguinal hernia, and we fixed that laparoscopically a few years back. But this case is different. There was too much bleeding here. That one was easier to make it stop and do the repair.
Yeah. Wow.
Why do you think this lady keeps having GJ ulcers?
Well, right now she won't have any because she hardly has any pouch, and we did also vagotomies.
Yeah.
We didn't show it here, but and she's not a smoker. She's not. Maybe she the main risk factor maybe she's a nervous Nelly, but that's about it. At least that I could identify.
Well, I've seen an ulcer erode into the left gastric artery. I had a lady right when I finished fellowship, probably my first 3 months in practice, that had a bypass converted back to a sleeve, and that eroded into the splenic artery, and she exsanguinated in a very spectacular fashion that was awful in the ICU. But I just, for the fellows, recurrent ulcers, you're working on that posterior side, could have splenic vein, splenic artery, left gastric, any of those can be pulled up into a chronic ulcer bed.
Cava can get in there, the recurrent.
Yeah, cava.
Someone in ASMBS, I want to say, or maybe Sages has a video that they always show of they get spectacularly into the cava, and it's just boom.
Bloodbath.
But the nice thing, the crazy thing is about, venous bleeding, right, is it can be a bloodbath, but also it's not as spectacular because of the intra-abdominal pressure too. So it's a little bit delayed, and then
And you can, we didn't talk about this, and I didn't do it in this case, but you can increase the intra-abdominal pressure more so, and that may slow it down. I didn't think really about doing it in this case. But if you go to 20 plus, obviously you don't want to keep it there for too long, but it can help a little slow down the bleeding if it's venous.
And for the fellows, if you're in a scenario like this and you don't have the extreme talent of Demetrius, it's also fine to pack that. And if it's hemostatic, leave it packed. You go back 24 hours later, it'll usually be sealed. These low pressure vein injuries, even a vein injury like that, pack some Nunit in there and some gauze over top of it.
If I had done this, I would have slept in her bed in the ICU with her.
Yeah.
I feel like I would be calling for the Everest pretty much immediately after seeing that amount of blood.
Yeah. All right.
awesome.
Thank you, everybody.
Yeah, thank you, Demetrius. Well, that concludes today in the session, and then I guess we'll be seeing everyone, hopefully most of you at DC at the annual meeting. What a cool, I don't know what to say after that video, Demetrius. You got everybody. It's like you get out of a movie theater and see like
I'm so happy
thriller, and you're like,
it's a distant
kicking it
memory
off.
at this point.
Well, thank you for sharing that, and thank you all for participation, and we look forward to seeing you all in DC. So thank you and have a good day.
Good
See
night.
everybody.
Bye.